Everyone knows who we are, so. And now we can start going around the room with our intros. So I see Kelly DeVito is first up, not to call on anyone, but
you're first
up.
Hi, good morning, everyone. Kelly DeVito from Horizons Counseling and Education Center.
Hi, Kelly.
Hi.
Thanks for joining us. Samantha.
Good morning, everyone. Samantha Summers. I'm from Long Island Cares. I'm the Nutrition Resource Manager.
Hi, Samantha.
Thank you. Maddie. McBullion.
Maddie McBullion, Horizons Counseling and Education Center.
Thank you so much. Dr. Danielle Craig.
Hello, I'm Dr. Danielle Craig. I'm the medical program admin from Suffolk County Department of Health.
Thank you. Kyle Barnacle.
Yes, it's Kyle Barnacle. I'm a account manager at Enterprise Engineering.
What was that?
I'm an account manager at Enterprise Engineering. We do staffing for the healthcare industry.
Enterprise
Engineering. Does that have to do with roadway design and downtown designs?
We do software development and
software development. Okay, well, completely off the mark. I'm sorry.
Yeah.
Okay.
Thanks for joining us. Rajiv Lajmi.
Good morning. I'm chair of the Applied Health Informatics Department at Stony Brook.
Oh, hi. Nice to meet you.
Thanks for joining us. Nadine.
Hi, good morning. I'm Nadine Wilches, CEO and founder of MindArch Health.
Thank you so much. Dylan Schwartz.
Hey, can you guys hear me?
Yep.
Awesome. Hey, I'm Dylan. I'm the street medicine liaison for the Long Island Coalition for the Homeless, fostering collaborations with both Northwell Health and Malloy University to provide medical care on the street to our clientele.
Awesome work. Thank you. Janet Romeo.
Hi, I'm Janet Romeo, and I work for the Epilepsy Foundation of Long Island, a division of Epic Long Island.
Thank you, Janet. Haley Boyle, great to see you again.
Good morning. Nice to see you as well. I'm Haley Boyle. I am the Injury Prevention Coordinator at Long Island Community Hospital in Patchogue.
Thank you so much. Sloan.
Good morning, everybody. My name is Sloan Yoselowitz. I'm the Injury Prevention Professional and Community Outreach Director for Nassau University Medical Center. We just opened up a wonderful facility that I think I want to share with you if you can give me a few minutes down the road.
Okay, thanks so much, Sloan. Oh, I love a cliffhanger. Okay, Selena Cabello.
Hi, good morning, everybody. This is Selena from the Nassau County Department of Health. I work in the Office of Epidemiology.
Thank you. Sue McCabe.
Hi, I'm Sue McCabe. I'm a PhD candidate at Medical University of South Carolina and a member of Eastern Nursing Research Society.
Thanks for joining us. Sue Palo.
Hi, I had to unmute myself. I'm the Director of Rehabilitation and Community Services at St. Francis Hospital. Good morning.
Morning.
Hey, Sue.
Karen Kirschbaum.
Good morning, everyone. I'm Karen Kirschbaum. I'm at Western Suffolk BOCES, coordinator of Creating Healthy Schools and Communities. And Alicia's home with her 8-week-old baby.
Oh my gosh. Congrats to Alicia.
Son. Thank you.
So exciting. Thank you. Vincenza Caruso.
Hi, Vincenza. I'm Associate Program Manager at Occupational Environmental Medicine of Long Island. It's part of Northwell Health.
Thanks so much for joining us. Allison Puglia.
Good morning, everyone. This is Allison Puglia. I am the I work with PSEG Long Island, and we provide low-income customers with discount programs and services.
Thank you so much. And lastly, certainly not least, Dr. Linda Mermelstein.
Hi, sorry, I couldn't hit my mute button. I'm Linda Mermelstein. I'm the Associate Director for Community Outreach and Engagement at Stony Brook Cancer Center.
Thank you for that. And we did just have some other folks join us. I apologize if you were in the waiting room. I'm so sorry about that. Adeswa, if you'd like to introduce yourself, I know you just got here. Sorry to throw you right in. Or Analia, if you'd like to go first, that'd be great.
Hi everyone, I'm Analia Trash. I use she, her pronouns. I'm with Stony Brook Cancer Center's Office of Community Outreach and Engagement, and I'm a program coordinator for the Cancer Prevention and Action Grant that we have here. Thanks so much.
Thank you so much for the intro. And then just two others that haven't introduced themselves. Claudia Alahi.
Hello, my name is Claudia Alahi. I'm the Community Outreach Manager at Catholic Health.
Thank you so much. And Adeswa, if you are there. If you're unable, it's okay. Maybe we'll hear from Adeswa later.
She's with the Office of Minority Health at the Suffolk County Department of Health Services. And Chris just popped on.
Yeah. We just had Chris join us. I know, Chris, we were just doing introductions. If you'd like to introduce yourself.
Sure. Hi, I'm Chris Hendricks. I'm the Assistant Vice President for Community Outreach for Catholic Health.
Thank you so much. All right.
I think we got everyone.
Yeah, so that's our group. Right.
Okay. All right. Well, as usual, welcome everyone. And I always appreciate you taking the time to join with us. We have pretty much a packed agenda, so we're going to go. I don't know if we're going to go quickly, but I want to get to everything. So we'll get going with our first agenda item. We have a tradition where we highlight or spotlight one of the collaborative members at each of the meetings. And this time around, who popped up was Nadine Wilches from MindArch Health. And so she's gonna just take a few moments and just tell us about, she works in the space of mental health and what she's doing. She's fantastic in terms of a researcher and being able to distill very complex issues and topics related to mental health. And she works in the space, I think, a lot with children too, to the layperson like me, so I understand what's going on. So Nadine, there you go.
Well, thank you so much for having me and spotlighting MindArch Health. It means a lot to me. So I've met many of you on the call, but not all of you. So I hope this introduction to me opens up a door that allows us to collaborate and network a little bit more. And maybe I'll drop my LinkedIn in the chat after this. But briefly, I'll tell you a little bit about MindArch Health. So MindArch Health is a social enterprise. And I started this project 4 years ago, although MindArch is just a year old in its inception of what it's become. And I think, you know, with every idea that we've all had, it starts with a belief. So I'm going to tell you my belief that drove this, and it's still my belief now, and maybe many of you agree with this, but the belief is that mental and behavioral health problems can decrease with the right set of conditions that improve stress resiliency and well-being. And so when I left, am I okay still?
Yeah. Oh, yeah.
Okay. Sorry, I can't see you all right now, so I just want to make sure I'm on track. So when I left 4 years ago, I left some more reactionary models of care, treatment, crisis intervention. I was clinical director for many years. And I was following this thread of opportunity, you know, how can we equip organizations better with an evidence-based model of prevention? That's what I was looking for. We were treating people, you know, in my opinion, far too late and it was taking a very long time to help folks back into a place of really good quality functioning and quality of life. So I followed this thread of research and interviews with a lot of people over the years and uncovered these best practices. And with the purpose of defining what are these proven factors that reduce risk and reverse these rates. This became a new benchmark for psychological health that can be implemented prior to symptom-based assessments that many of us are using. We are able to then define really targeted points of intervention that within the population. So this is a population health model for organizations to define, you know, who are those high-risk populations, what are the highest needs in terms of stress resiliency and protective factors that improve psychological health, and how can we intervene at the population level. And we realized very quickly that technology can help speed up this process. If you've ever tried to do a complex evaluation project like this, where you're looking at multiple factors at multiple different levels, context, risk factors, and health factors, that it takes a long time to code them. So we use technology that can help speed up the process. Our technology is called MAP, MindArch Health Automation Pathway, and it helps analyze and interpret this multi-factor data. It gives us immediate feedback and allows us to deliver within the software an automated prevention plan with all of the information that is put into it. So we support schools, colleges, and community health organizations with this upstream and proactive approach. And I think some of the benefits that we observe is that this reduces the burden on healthcare and counseling centers. It builds capacity in the organization. It can also validate the effectiveness of our solutions to make sure that we're on the right track with a lot of these health promotion and population health interventions, which sometimes are difficult to assess. And then with that, these targeted solutions help us optimize limited resources that are, can be now targeted specifically in the highest area of need. And obviously the main goal is to improve well-being, mood, behavior, cognition. So that is a very short and quick synopsis of what we do here at MindArch Health. And it really has been a fun journey to build this and put this out into the community and schools. And so I'd love to be able to connect, like I said, with anybody who I haven't met, and share resources and strengthen each other's organizations. So thanks again for having me. And I mean, I don't know if we can answer any questions, but if not on this call, then later.
Yeah, sure. If anyone has any quick questions for Nadine, this is a good time to ask them. So as we're going to move into talking about the prevention agenda, which is all about measuring, tracking, and measuring the results of interventions and strategies, I'm curious you say that one of your strengths or one of the byproducts of this software or program that you have is the ability to get that data there, that quantitative data. I read it someplace. So that, I think as we, maybe can talk a little bit more about that, like how does this happen? I mean,
yeah,
how do you do this? Because that's what most people struggle with, is trying to evaluate what they've done.
Yes, 100%. So we have a few different points of data that go into the software. We do a contextual analysis, which is a qualitative study of what's going on in the environment, the conditions that support mental health right now, and things that might be actually, a burden or a stress or a problem within the environment. And that gets summarized and offered as insights. We also then look at risks, so factors that increase people's risk for developing a mental behavioral disorder, like childhood abuse and neglect, parent rates of mental illness, or learning problems, etc. So we look at all of that in the context of the community. That's automatically scraped from national data sources. So we have to interpret all of this data with caution. And then we developed two survey tools that are quantitative, like you said. One is a measure of psychological health. So what are the positive factors that are promotive of good mental health? And a measure of resiliency factors. So what in this specific environment is conditioning, stress resiliency and positive protective factors, essentially. And so those are just what we do is just data analysis in the software. It just does the calculations for you and gives you a visual representation. And then lastly, we have another qualitative piece of the puzzle, which is a summarization of lived experiences. So we take that goal and say, okay, well, this is the highest need, but how are people really experiencing this? And so the people who are key stakeholders that are invited to answer these questions, and ideally this is a diverse representation of the population, those get summarized and used as insights to drive the action planning, which is also so we use a lot of summarization of the qualitative insights, and then quantitative is just data analytics.
Okay, thank you so much, Nadine. I don't know if anybody.
I will just say for summer, I cannot get this bottom toolbar to not display, but Nadine's contact information is on this slide, which will be circulated after the meeting. So you will have access to that in the slides, as well as I know Nadine just dropped her LinkedIn in the chat. So thank you so much for that, Nadine.
Yeah, thank you so much for Nadine and all your sophisticated insights. I know we've had quite a few conversations about research, and Nadine is a great resource for that. She has a very analytical mind and a compassionate heart to go with it. So that's great. So we're gonna talk about the core clusters right now, and I guess I'm gonna kind of hand that over to Brooke, since she's pretty much in charge of the core clusters. And what these are voluntary groups, right? We call them core clusters, but they're really work groups who are working on, they decided upon 3 topic areas and have a deliverable project that will benefit and be owned by the entire group, collaborative group. So I'll turn it over to you, Brooke. You can give us an update.
Yeah, so thank you to everyone, who has been participating in the clusters. It's really exciting to see some of these deliverables actually kind of coming to life and forming. And Hannah's been really instrumental in participating as well. So we're really glad to have, another internal team member helping out with this. And Alexis Zizzo, also our intern who's not here today. She's also been great with that. So thank you all for your efforts so far. Just to kind of recap what we're doing in each cluster, for the mental health cluster, we decided to put together a career guide to encourage anyone, thinking about a career path to consider a career in mental cognitive behavioral health. So that's for the mental health. We really have, thanks to Nadine, really outlined everything, all the elements for that guide. And now we're really just kind of plugging in a lot of the information and fleshing out the sections. That guide is going to live on our LIHC website, as well as, really all the projects that we're working on are going to live on the website. And if there's anyone who would like, I just saw Nadine come on, if there's anything you'd like to say about the mental health cluster, please feel free, anyone who has participated. So that's for the mental health.
Yeah, one thing about the mental health cluster, what I learned is there are so many intricate, I don't know if that's the right word, but diverse jobs in mental health that have not really been traditionally explored, I think, in this way. So that's what's making this resource a little bit different.
Yes. Just to add to that, we are going to be adding a section that shows all of the Long Island programs that are available for folks to seek, certification, degrees, and all of that to enter the field. So yes, it will be unique in that way, for sure.
It's different.
For the chronic disease cluster, we have been working on a guide for young adults as they transition into adulthood and managing their own healthcare, obtaining their own health insurance, educating them about the importance of, lifestyle and how that can really affect your health outcomes. So like with the mental health guide, we really have all of the elements in place, and now we're really just kind of working to flesh out all of the different resources and hyperlinks and things like that. And then for the cultural competency health literacy cluster, we have been firming up our outline for our static module. So as you might remember in the past, we had a Train the Trainer CCHL course that we housed on the Long Island Health Collaborative website. This one that we're working on now is just going to be a static module, about an hour and a half, and it will be something that anyone can take at any time. And that's we're really at the same phase with all of them, where we have the layout all set, the outlines all done, and we're just kind of filling in holes and fleshing things out.
Yeah, and the chronic disease one, the focusing on that kind of young adult who's transitioning particularly a young adult who has a chronic disease, and there are many that do, who's transitioning from the parents' insurance or who's going to college and kind of needs to take care of themselves now, or just really should be taking care of themselves. They turn 18, 19 as an adult. And that really was a gap, we identified a gap in that age group about knowledge and efficacy to understand and deal with their issue, the insurance part of it, everything, keeping medication adherence, appointments, all of that. So that's why that's very narrow focus, and that's targeted to that group. And each one of these core cluster projects, we of course will do a social media campaign, use traditional media outlets and marketing techniques and whatnot to get the word out there. And the nice part about this is, yes, the core cluster members who work so very hard on this are certainly connected to this and will be prominently identified, but this is something that's owned by the entire collaborative. So this is collective impact in action, and it's for you and to be used by you.
And entirely voluntary, so I do just want to reiterate our gratitude to you all for your participation. It's really you all doing this work on the ground to address these needs, that each cluster focuses on. So it's really your expertise that we rely on to make these as great as they are. So thank you all. And if you are interested in joining a cluster and have not joined yet, please do not be shy about sending me an email. We would love to have you. And we will be reaching out to coordinate our next bi-monthly cluster meeting in November. Look out for an email from Ramona Bailovsky. She'll be reaching out after this meeting. We just wanted to see if there was anyone else interested in joining before we sent out.
Yeah, we meet on in between the collaborative meetings, so we have can show the progress that we're making.
Yes. All right. Yes. So we are very excited. We are going to be hosting a poverty simulation. Hannah, do you want to talk a little bit about that?
Yeah, this really stems from Hannah happened to go to a poverty simulation and did such a fantastic report on it at the last collaborative meeting that the Nassau County Department of Health reached out to us and asked if we would want to work with them and sponsor another poverty simulation. So that's really how that all came to be.
Yeah, so if you were at the last meeting, I did a little bit of a rundown about my takeaways from the poverty simulation. What the poverty simulation really is when you come to this event, you're assigned a character, a kind of a living situation, maybe different living conditions. For example, my character was a 65-year-old woman who had been partially paralyzed by a stroke, and trying to navigate some of the challenges that we are obviously very aware of: transportation, working, trying to pay your bills. And so it is, although it's not a game, like we've said this before in the last presentation, it is a fun, but also really eye-opening experience to be a part of. Where you really get to understand firsthand how individuals living in our community who are struggling with their finances or living in poverty really handle the day-to-day, and how that can have an effect on health. So really, this is great for anyone to be a part of, but we have actually at the bottom of our slide here that it's really decision makers and people who maybe have been a little bit far removed from working with the community. That's really imperative to it's a good way to immerse yourself in the experience of it and kind of ground yourself in why we do the work that we do. So I think this would be a really great opportunity for anyone in the collaborative to be a part of. It's going to be on Friday, November 15th. This is 3 hours because it is, or is it 4 hours?
3, I think.
3 in total, yeah. So it's 3 hours long. We do recognize that that's a little bit long, but I think this will be a really great experience to be able to, number one, network with everyone within the collaborative. You can kind of meet everyone in person. I know it's been a while since there's been an in-person meeting, but also to partake in this activity and kind of go back to your organization with all the lessons learned and that kind of firsthand experience. So we think it's a really great and worthy event to come to. It's going to be at Nassau Community College.
Yeah, and
just drop the link in the chat here.
And of course, we will have breakfast, or continental breakfast for you, because you can't spend all that time without some kind of nourishment. And what we're going to be able to do at this poverty simulation is, just before it gets started, we, as the Long Island Health Collaborative, as you know, collect data about communities' health needs, both at the individual and their perception about their own health needs and their community's health needs, both for the public. We have a public survey, and then we reach out to the community-based organization leaders. And so we are going to have that, and this is in preparation for the next community health needs assessment cycle, which I'm going to talk about soon in the meeting. Going to be able to distribute that and have that survey completed via QR code. People can just sit there and quick answer the questions right in real time, and get a good chunk of community-based organization leaders to take that survey, because everybody's got survey fatigue at this point, and then offer anyone who's interested the opportunity to engage in a follow-up key informant interview in the beginning of next year. So we're kind of killing two birds with one stone here, since we will have those CBO leaders in one room. I think Suffolk County is going to hold one down the road as well. Since this is well into Nassau County, we were trying to find a location that was mid-county, very hard to find. So that's why we decided to stick with Nassau County Community College, but I think there's going to be one in Suffolk as well. And yes, we would like key decision makers. We'd love to get the CEOs there. I know that's like pie in the sky, but there's nothing like experiencing it firsthand. And this is, again, simulation. It's not really, you're not really out on the street, but I think as we become senior leaders, become more and more removed from the actual barriers and problems that our patients and clients face. And every so often, it's really good kind of to stick your feedback into that. So we're hoping we'll have some senior leaders there.
We'd love to see you there, and thank you all
Yes.
on the call. I know there are a few Suffolk folks at desk one. Dr.
Yes.
Craig, thanks for your help in organizing this. Alrighty.
So we're going to take a quick few minutes. I have
Frank is here on the
Frank
call
is
with
on the
us.
call. Okay, Frank Winter, who works for the Centers for Medicare and Medicaid Services, Partnership Manager in New York Regional Office. He's going to talk a little bit about the Inflation Reduction Act and some Medicare updates, which I know, what was it, 2 years ago that was enacted? I can't even remember, but I know it was enacted not too long ago, and has resulted in Medicare being able to reduce out-of-pocket costs for seniors on prescription drugs. I don't know if the $35 insulin cap was part of that. I think it was. And I also think being able to, the government to negotiate directly with pharmaceutical companies was part of that too. And I think the 10 or so drugs were selected, and that's kind of, the negotiations are starting. I think that kicks in 2026. Did I get that all right, Frank, sort of?
Yeah, that's right. We just announced the end of the first round of negotiations. So we have the prices out for the drugs that will be affected in 2026, and we'll have lower prices for those medications. And then in February of next year, there'll be a new round of drugs selected that'll be added on to negotiations and will hopefully be available at the negotiated price in 2027. So they're gradually adding on drugs. Yeah. So
Frank, before you take it away, I just saw we had a raised hand in the audience. I just want to double check there were no questions before we move on.
Sure.
Okay. I don't think anyone is speaking up, so
maybe it was sometimes
please excuse
by
me.
mistake.
Sorry for the interruption there.
No worries.
Take it away.
No worries. So good morning, everyone. So, open enrollment is fast approaching. 2025 is fast approaching. So thanks so much for including me in your meeting to provide some updates. And Janine, thanks for including me. Just want to talk a little bit about what's coming relating to the Inflation Reduction Act. We talk about the drug negotiation. We also talk a little bit about what's in the rearview mirror, the insulin price cap. Also, one other thing that's sort of in the rearview mirror and is already in effect is recommended vaccines under Part D being available without cost for folks. I know for a long time, a lot of people, the one was the shingles vaccine that a lot of folks had trouble getting at an affordable price. So it seems like from what I've seen, the numbers are up in terms of the people getting that vaccine, but there are of course other vaccines available as part of that change. So what's coming next year, and I'm going to show in a minute some resources that are available on our website, but what's coming next year, two important changes under the Inflation Reduction Act. The first one is the biggest one, which is a $2,000 maximum out-of-pocket cap for people with Medicare Part D. So for their Part D drugs, they shouldn't pay more than $2,000 out of pocket. Now, as in the past, your plan could have prior authorization requirements or step therapy requirements before a medication is covered. Some drugs may not be listed on the plan's formulary, even though we have the same requirements we've always had for the plan formularies as protection, so that people have a wide range of options in terms of their prescriptions. But it's an exciting, change. It's going to save a lot of folks a lot of money. But open enrollment is just as important as ever, even with that cap, because you still need to pick a plan that works well with the pharmacy that you want to use, that covers your prescriptions with as little restrictions as possible, and that you're comfortable with. And so during open, and of course, a lot of people are getting their drug coverage through a Medicare Advantage plan, one of the health plans offered under Medicare. So then there are other factors for them to consider as usual, are my providers part of their network? What are they charging for other services? What's the maximum out of pocket for that plan for health services? So that's why open enrollment is always so important, and it's just as important even with the improvements in Part D. There still may be some people who, are in a plan that, they're not happy with. Maybe the premium went up, they didn't compare, and they didn't realize their premium was going to go up next year, or they didn't realize that there were some restrictions on some of the drugs that they're taking. Or, you sign up for something with a low premium and you don't look into what's covered, and you have a problem that way. So, as always, we encourage folks to review their coverage. Of course, folks can use Medicare.gov website. They can call 1-800-Medicare, but there are also the local counseling programs in New York State. It's called the HICAP program. There's a HICAP program in Nassau County and Suffolk County, every county across New York State. And there's similar programs all across the country in US states and territories. So people can get connected to those programs. On the back cover of their Medicare New Handbook we send out to everybody, there's that information. They can go to Medicare.gov or call 1-800-Medicare and get a referral. But those sources also can, they can actually take a look at some of their options by talking to someone over the phone at 1-800-Medicare, or by entering their information through the Medicare.gov website. And there are some new things on the website to reflect another improvement for some people in the Medicare drug plans that's a result of the Inflation Reduction Act. The other big thing is there's what's called the Medicare prescription payment plan. And it's new. I think it would have even had a bigger impact in the old days where people's out-of-pocket costs were much higher. But there still will be some folks who may benefit from this program. So what this prescription payment plan does is it allows you to spread your costs out over the 12-month period of the year. So let's say you're taking a very expensive drug, it costs you, $800 every time you fill it every month. You can, instead of, paying, essentially you'd hit your $2,000 cap in March if you had a drug like that. And that's good news that you wouldn't have to pay more after March, but you would have to pay that whole $2,000 of cost sharing over the first 3 months of the year, unless you had some other coverage to help you. So what the prescription payment plan does, it allows you to spread those costs out over the 12 months. But it's not beneficial to everybody. If you have smaller cost, lower cost prescriptions, it's not going to really help you. For some folks who have Epic, especially at the Epic fee plan, it may not help them. For those who have extra help, what's called the low income subsidy or Medicaid, helping them with their Part D prescription drug costs, it's not going to help them because their co-payments are very low anyway. So, it doesn't help everybody, but for some folks who don't have other coverage, it's going to help them and are going to have a lot of those costs hit them early in the year, maybe on a fixed income. This is something to look into. There's information on the Medicare website about it. People can actually get a month-by-month breakdown on the plan finder on Medicare.gov of what they're going to be expected to pay for their prescriptions if they sign up for their program versus if they just, don't sign up and just use their regular Part D coverage. And again, people can only sign up through their plan. So if folks are interested in it, they have to call their plan or go to their plan's website for information about how to sign up for it. So now I'm just going to share my screen and show some resources for folks to get a little more information. And I'll also drop some of these links or all these links in the chat so people have access to them. Hold on, I just need to move something here. Okay. So first we have a fact sheet out that explains the prescription payment plan I was talking about, how it works. I'll share that with folks. We also have more background information available on the Inflation Reduction Act, some of the things we were talking about, like drug negotiation, how does that work? The savings for insulin, how does that work? And vaccines, and also materials you can share through social media or with the folks that you serve. Last, I wanted to share our open enrollment outreach and media materials. These are the materials that include reminders about open enrollment. And as I mentioned, even though there's some great improvements to Part D, because of the things I talked about, and also because some folks may want to look into this prescription payment plan, it's really as important as ever for folks to do their research and get help if necessary from a counselor in comparing their options going into open enrollment. And as a partner, if you're active in social media or you have clients that you serve who have Medicare, these are resources you can share, whether you have a newsletter, email blast that you do, social media, help us get the word out there. One of the easiest resources to share is this document about your yearly Medicare plan review. And it's just a reminder and basic information about open enrollment and what folks need to do. And it's really important because people are inundated with advertising during open enrollment. We all see those ads with Joe Namath and Jimmy Walker and everybody saying, hey, call and, get information, give your zip code. There are unbiased sources of information, like 100 Medicare, like those local health insurance counseling assistance programs or Medicare.gov, where people can make a really informed decision and comparing their options and see what might work best for them. So we appreciate if you can help us get the word out about that. And one last thing I'll mention is training, which is I'm also going to share the link for our national training program. They have a number of trainings and webinars throughout the year. One of them is the Open Enrollment Boot Camp, which the first session was yesterday and will be recorded and available. And then there's a second session this afternoon. And the two sessions cover different materials, but it's something worth tuning into. We also hope to do an in-person training in Long Island for community partners sometime soon to talk about our programs, but also Medicaid, the New York State of Health with some of our partners. So hopefully we can do that. And thanks everyone for your time. I'll see if any questions.
Yeah, thanks so much, Frank. Does anyone have any questions? And I see open enrollment starts October 15th, so that was going to be one of my questions. And I think it said it ends December 7th. Was I correct?
December 7th, October 15th through December 7th for Medicaid.
Okay, so October 15th for Med, is right around the corner. So
yep.
It's rather timely. Does anyone have any questions? I have a couple of comments for those of you who might not know, Medicare, those of us who work in Medicare and Medicaid, the insurance space, we know what Medicare, A, B, C, D, we know what all that is. So A is hospital, right, coverage. B is your outpatient physician coverage. C is Medicare Advantage. And Part D, when we talk about the parts, is the prescription plan. So I know not everyone on this call works with an older population or a disabled population who might be Medicare eligible, but just always kind of like to present that qualifier because sometimes you hear all these, ABC, and we're not sure what it is. And just wanted to remind everyone that also here at the Nassau Suffolk Hospital Council, we have we enroll for the ABD program, which is aged, blind, and disabled, and have certified enrollers who can do that and help individuals. So just always keep that in mind, and you can reach out to me if you want more about that. So thank you, Frank, for this very timely information. That's gonna.
Sure, and can I add one thing, Janine?
Yeah.
I just wanted to mention that we a lot of times too, we remind folks that folks are not in isolation, they're in a family. So even if you're working with someone who's not eligible for Medicare, a lot of times they're helping out their mom or their dad or their uncle with their costs. And, so I'll cover that prescription that wasn't covered by your plan. Well, actually, if you're aware of the resources to better help that family member, then you can save money for the whole family if they have the best coverage that they need and you're not spending as much out of pocket to help them out. So that's one of the things I always mention, if someone comes up to me and they say, oh, well, I don't have Medicare. And it's like, oh, well, do you have parents?
Right. That's
talk to them about their coverage, because that can be important for the whole family.
Absolutely. That's a really good point to make. Anyone have any other questions?
I see Odessa has her hand raised.
Good morning. I just saw that Brooke, you put the New York State enrollment number there because that's what I was looking for. Just because it is really complicated to understand this when you are not directly signing folks up for insurance. But I work at a local health department, and we do have someone that actively goes out and engages our seniors. So would that be the number that I can use to, kind of direct them to Medicare if needed?
So I just want to clarify, the link that I had put in the chat is our coverage for healthcare website where we have information about the enrollment services we do offer at Nassau Suffolk Hospital Council, but those are only for eligible populations. So the main number, I'm not sure what that would be.
Frank, it's 1-800 something. There's a main number, right, that you can call?
Yes, I just pasted it. That's the statewide number. So folks can get connected. I also can find the Nassau and Suffolk and put them in the chat as well.
Thank you.
Okay.
Thank you
Thanks,
so much.
Frank. Any other questions for Frank?
Don't see any hands
Don't
raised.
see any hands raised. Don't see anyone else asking questions, so. Thank you again, Frank. And yes, if you put that additional information in the chat, we appreciate that.
Thank you so much.
Oh, and I did see Sloan had in the chat that he wanted to talk a little bit. He said he attended the last poverty simulation. Sloan, did you want to say something about that?
Sure, I did attend it. It was amazing. At first, there was a lecture. I believe it was at New York Tech. And
Yeah.
after the lecture, we had lunch, and then they did the simulation, and they put each person of the group in who attended into a family, and they gave us a situation on how to get certain services, and it was very challenging. I lost my lights, I lost my power. Many times I wasn't able to get to work. There was no one to watch the kids, but it was a wonderful simulation and really showed how hard it is for people that need these services desperately to almost attain them. So one of the things that we're doing, and I think it's hopefully going to, I'm really excited about it. It's going to be maybe, I think, a good model that maybe we can take to other places, is we just set up a community outreach space in our lobby. And if anyone would like to come see it and view and tour, feel free to reach out to me. And I talk about all the different great outreach, evidence-based safety and injury prevention programs that we do. And then also every day, a different office from Nassau County is coming and offering services from the Department of Health. So anywhere from emergency housing, food, they're going to have a food pantry, clothing. And it's really, to me, is going to be wonderful, because a lot of times we have people in the hospital that might be staying there because they have no place to go. They have no clothing, they have no food, they have no support. And instead of having to go through the whole system, we're identifying it's such a big problem. There's going to be one place, one desk where all their community needs assessments can be kind of set up. It really just started about 2 weeks ago, and I think it's going to have a tremendous impact. I'm going to try to track quantitative data and have a report and maybe do a study on it, but we're really, really excited.
So that's going to be in the lobby, you said, of NUMIC?
Yeah, so if you remember where we did the second annual bike and pedestrian safety symposium, right across from there was a space, and we're in that's where it is, and I'm really, really excited about it.
Yeah, it sounds great, to help people really where they are, right? So it's easy access. And is this the program that you wanted to share earlier, that you had mentioned something new was happening at?
Yes. I mean, my ultimate goal is, again, with safety net hospitals, I think $20 to $25 billion is spent annually throughout the country. That's an enormous number. And the thing is, when we use that term, quantitative data, impact, how are we showing a difference? Is this stuff working? Well, they think, I saw a big study out of a lady, Paula, I can't pronounce her last name, but she's out of, she does a lot of health equity, and she thinks of that 25 billion, about 7.5 billion is just wasted. And if we can try to figure out how to, change that a little bit, so that money really is going and addressing to the needs and having that impact, it can be huge. So that's really what my goal is. And on the research, I'm going to try to set up and do and see if hopefully down the road makes a big difference.
I would be interested in seeing how you track that data and what outcomes you find, if it's been effective or not, having something located there, as would probably your fellow hospitals, right? That and the county health departments would probably be very curious to see that data from that particular service that you've implemented. Nadine had a question.
Oh, I think she might have just been applauding.
Oh, she was applauding. Oh, she was applauding. Okay. Thank you so much, Sloan. Doing great work there as well.
Yeah, thank you.
Yes, absolutely. Okay. So this kind of is a good segue into the discussion that we're going to have about the next upcoming prevention agenda cycle, 6-year cycle, 2025, 2030. This most closely affects hospitals and county health departments, but also affects community-based organizations and any other institution or facility that's providing services, social support services, even clinical services. So I'm just gonna kind of go through, bring you all up to date as to what's been happening. I am on the statewide, I think Chris is on it. Chris, are you on that state? And, oh no, yes. I'm on the Public Health and Health Planning Council ad hoc committee for the prevention agenda. And then there's another statewide committee that Chris sits with me on, but that's through Haney's. And so the Public Health and Health Planning Council, they are the regulatory agency with people appointed by the state and who sit on a board and review all kinds of decisions regarding expansion projects that hospitals and other healthcare providers want to engage in, et cetera, et cetera. And one of the charges is that they oversee the state's prevention agenda and what is going to be focused on and asked of those participating in the prevention agenda and the reports they have to file in the upcoming year. So FIPIC, for short, they adopted a new framework in September at their September meeting, and it is heavily focused on social determinants of health and aligns with the CMS's Healthy People 2030, one of their topic categories, which is social determinants of health. So now we have 5 domain areas, right? And those social determinant of health domain areas are going to be looked at by a work group who will meet in October and November. That's been identified by the state of representatives of all different kinds of organizations throughout the state. And they're going to look at evidence-based interventions that hospitals might be able to employ, that county health departments might be able to employ, and further guidance. And then once that is done, the FIPIC then reviews the work group's suggestions and guidance and approves and releases that to the hospitals, who that always happens, and the local health departments. So that's where we are. And a full, what's called community health needs assessment, extensive, comprehensive one, which will inform an action plan, will be due the end of 2025. Okay, so that's where we are for the new prevention agenda cycle. Let's see, what's next? Okay, so what I did, and those of my colleagues who, I need water, I was just gonna say, no, my throat gets dry. Those are my colleagues in the health departments, in the hospitals, and also community-based organizations who've been through this many times before with me. I looked at the last report template, because what I will do after we have all our meetings back, when probably in the spring, is I will write a sample report, a template, one for Nassau County, one for Suffolk County, and you can use parts of it, all of it, whatever you want. But anyway, I looked at the old template and I looked at the new template to see what were some of the changes. And really what's happened is they moved some sections around. Some parts of it that were included in other sections are now standalone. Components have been reordered. And I actually think it makes more sense. So when you see it, it actually makes more sense. They've added at the end a Appendix A, which is a checklist, a self-assessment. Thank you so much. She even got my crystal list. She knows I like my water at the crystal list. Ooh. So you have to fill out, I'm so sorry why this happens, this Appendix A, and you just check off that you did this section covered, you have that section covered, so that's new, which is not a big deal, right? Actually, it's a good idea, I think, so you make sure you're doing everything you're supposed to do. You are now going to have to select 3 priorities. It used to be 2, but the priority selection in the narrative report is not identified till further on in the report, where it had been identified much earlier on in the last template. The state is still working on that Excel work plan, and that's everyone's favorite document, right? That's the one where you have to go in and there's a drop-down menu and you have to pick objectives, and then first the goal, then the objective, then the measures and the indicators, and then who are your partners helping you, what are your interventions, right? So they're working on that. And that will be ready hopefully soon, right? So you can look at that for next year. So they are working on that. And then in the written template report, there is, I found like a chart that I think it's just to help explain how we're supposed to do this, but I thought it was helpful. It helps in directing you how to select your priorities and really encouraging the use of measurable SMART objectives, and they want one indicator for each priority. They are talking about, I think they're gonna probably revise the dashboard, but I'm not 100% sure, but they're talking about taking the 2030 goals, objectives, indicators, and measures and trying to align them with what the state has already there, along with all of those, the 3 priorities they want you to choose. So I have to follow this along and see how it all plays out. And of course, there's a much greater emphasis on health equity. You very specifically have to define those populations, very specifically note the strategies that you're going to use that are directed specifically to those populations, and the resources. Where are you getting the resources to do that, and how will they be allocated to the populations of greatest need? So there's a little bit of change, and it's the next slide to work. Priorities. Okay, so the next slide is going to talk about a work group that we will put in place here through the collaborative to help the counties and the hospitals, and of course the CBO leaders who are part of this, wade through this process over the next several months and get everyone ready so that they can do their submission at the end of next year. So I don't know if you can see this, I don't know if we can make it any bigger, but this is their framework, right? So the vision, oops,
Make it a little bigger.
a little bigger, yeah. The vision had been, and we are New York wants to become the healthiest state in the nation. They still want to become the healthiest state in the nation, but they've modified their vision, as you can see, right? Every individual in New York, they want them to have the opportunity, regardless of background or circumstances, there's the health equity part of it, attain their highest level of health across the entire lifespan, right? So it's a little bit more of a expanded vision. You see their domains on the left are the ones that are listed in Healthy People 2030, economic stability, social context, blah, 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 blah. There's 5 of them. The priorities themselves are more topics, right? So the 24 are the little boxes. If you look at those little boxes, it says poverty, unemployment, and then it says healthy eating in the next one, access to community. Those are the priorities. So they're very general in my mind, which I think is not a bad thing because they provide for more latitude. If you recall, on the last prevention agenda, there were 5 priorities to choose from, and one was prevent chronic disease. Another one was improve access to vaccines and something with communicable diseases. Another one was about women's health, substance misuse and mental health, right? They were more specific, and then they had objectives underneath. This time around, they're taking those 24, which I say are kind of topic areas, just topics, and asking you to choose 3 of them. And then they've further broken them down into what I call descriptors, right? Economic well-being, mental well-being, safe and healthy communities, health insurance coverage, pre-K student success and educational attainment. They've just given them, and they're also derived, right, from the domains, the social determinant domains, but they're not the priorities to choose from. The priorities are those 24 boxes. Tobacco, cigarette use, alcohol use, so suicide, depression. It's just great, I think much greater latitude in when you're designing interventions and deciding what you're going to do. So that's that. All right, so stop me if I'm going too fast, right? Because I've been studying this for the past couple of weeks trying to get this right. So we need to select the 3 from that list of 24, which I pointed out, right? That will inform the community health needs assessments that the hospitals do, the community health assessments that the counties do. It's really the same exercise, right? You're trying to find out what are the needs of the community. Of course, doing it jointly is always encouraged, and that's what the collaborative has been helping with over the past 10 years, 11 years, believe it or not, at this point. And then, as I said, they're derived from those social determinant of the health domains from Healthy People 2030. So.
We have a hand raised, Dr. Mermelstein.
Mermelstein, yep, of course she has a question.
Okay. So I just want to clarify. So does that mean then that we would need to change the survey questionnaire that we have to be more aligned with this, or is it already sort of aligned with this? It's just, I mean, does it ask questions? It get you to figure out which of these would be priorities?
That's a good question, Dr. Mermelstein, and from my memory of our survey, and this is what the work group, when we get to the next slide, we're going to talk about, pretty much does hit all these areas. And when I was talking to the state, I said, the way you've changed this framework from what you had, just the five priorities, and the way you want this information presented in the template, has it really changed much? And they're like, no, it's still basically asking for the same information, but just kind of in a different way. And that's why I did a side-by-side comparison of the two, and I found that to be the case. Regarding the survey that we've been using, we have the Community Health Assessment Survey, known as the CHAS, which we have been deploying on behalf of all organizations that are participating in the collaborative. Since 2013, it's been the same, which allows us to see trending over time and whatnot. I believe we're probably going to be okay, but when the 2025 CHNA, CHA work group convenes, which we're going to talk about in a little bit, and meets over the next 5 months or so, once a month, as we go through data and decide what collectively, what the priorities are based upon what the data show us. That first thing we're going to do is review the survey and come to an agreement. We did it the last time and we changed it, we made a couple of little changes. And we'll do the same thing as a group and get consensus on it again. So I hope that answers your question.
Yeah, that's helpful. One other thing I just want to mention, I'm gonna.
Hello? We lost you.
Sorry, I hit the button. I'm gonna put into the chat a resource that we have on our website, which is like a mapping program that has all kinds of information from the census, from BRFSS, all kinds of health statistics and information that anyone who's doing their community health needs assessment can use. You can take screenshots, it tells you where the data comes from, and it's continuously updated. So as BRFSS gets updated, the information flows. It's kind of similar to the dashboard website, but it's got some additional information specific to Long Island. So anybody can feel free to go on it and take a look.
Oh, thank you so much. Such a great resource. I know that the state I don't know if they've sent the Dear Administrator letter out to those who are charged with conducting the community health needs assessments yet, but they do have a extensive list of resources where you can find data. And I think it's a lot of the same data sources that you just mentioned. So, and we as the collaborative will be looking at all of that. We don't just look at the primary data that we collect through the surveys and through the CBO surveys and the key informant interviews, but we look in totality at some of those other data sets, secondary data sets that are out there. All right, let's see. So this leads me into, as we did last time, we convened what I call a prep work group, CHNA, CHA work group, right, to come together. I believe I would like to start meeting in October, just to put our heads together, to start looking at the survey we currently are using, get familiar with this new format of the prevention agenda. I'm certainly going to have questions of the state as I'm moving along. We're certainly going to have questions once those subgroups of the state release their guidance in December. And so we are offering, you can take a screenshot. Well, they can
Yeah,
take,
you
you can
can
take the
scan
QR, scan the QR code, or you can go to that link. And we just use a service called Calendly where you can select what's best time for you, and then of course, the time that has the most votes is the time for the meeting that we will hold, and it'll be virtual and we'll, have a specific agenda and kind of just get us going. I don't know if you would want to take time now. Well, first of all, because we got a lot of different organizations on this call. Certainly the hospitals understand that they have to do this both for federal and state reasons. The counties know they have to do this for state reasons, required by the state, and if they're seeking Public Health Accreditation Board accreditation, they have to do this. But community-based organizations do not have to do a community health needs assessment, although you may do one anyway. But I wanted to just emphasize your important role in this as well, because as we know, it's a collaborative process, hence Long Island Health Collaborative, right? That a community-based organization like Long Island Cares, I think they're on the call, Horizons Counseling, what are some of the other ones on the call? Can't remember. You are working with perhaps hospitals. You're working with Northwell works with a lot of community-based organizations. I know they're on the call. You are working with the counties, right? Counties have some programs in place and you're working with the counties. You might be partnering with them, providing blood pressure screening at local libraries. You might be partnering with a hospital that has a mobile medical van, whatever it might be. So you have an importance in this because you can't get out into the nitty-gritty of the community without utilizing those tentacles into the communities that those community-based organizations have. And so this is important for you to be involved with as much as it is for the hospitals and the local county health departments. Also, any data, as you know, that's collected and analyzed is there for you to use. So you as a community-based organization, as I've said in the past, can pull data, and we do it by zip code when we analyze the CHAS data and put it into a Power Pivot Excel format you can manipulate. You might want to use that when you're applying for a new grant or to show what has happened in a particular zip code where you're working or have some assets in the community. Just because you want to see that, maybe you want to share that with your board of directors, right? So there's usefulness for you both through the process, before, during, and after. So I just wanted to explain that to those community-based organizations who have to every year listen to me talk about this prevention agenda and this exercise that the hospitals and the counties have to go through. And I think finally, jumping back now, because we're still in a cycle, we're in this current cycle, 2019 to 2024, goes in 6-year cycles. The state has that work plan that we all have come to love, just love so much. It's a little confusing to fill out when it's asking for objectives and indicators and intermediate indicators and outcomes. It gets a little hard, just like fitting a round peg into a square hole or vice versa. A square peg into a round hole doesn't always work for everyone. So that's always a source of a little bit of frustration. That's going to be due as an update the end of this year, and they're capturing 2023 and 2024 data because for some reason they sent the note out last year and said nobody had to report in 2023. I have no idea why. So we were all happy, but guess what? Now they're making us do it, so now we gotta go backtrack and find the data for 2023 and 2024. Okay.
Which we had already, we're just plugging it in.
We as the collaborator had already.
Right.
So we're able to provide everyone with very limited data because we don't offer programs other than we do some we'll walk with docs and
Some campaign metrics,
some
things
campaign
like that.
metrics on different campaigns. So we have social media metrics, we have a number of walks we've held and where they've been held, right? Some might have been held in your community, some might not have been. And we always do pre and post analyses of those walks, so there's a data point there. We'll get those metrics out to collaborative members mid to late November at the latest, and you can add that to your Excel work plan if you want, or just have it and as a resource. Okay.
And for any folks on the call who might need that data sooner, I know, Claudia, you may definitely please reach out to me, anything you'd like, just let us know when you need it by.
Right. We used to be able to do more when we had state funding. The collaborative was funded for 5 years by we were the Population Health Improvement Program contractor for this region. We lost that funding, but we've been able to maintain the infrastructure of the collaborative through the years and continue to deploy that survey on a yearly basis, and we'll have data available for you to use. I think I should stop and ask and have any questions, because that was a lot of information that I just shot at everyone. Selena, you might want to jump in, because it's a little different for the counties now. You're on a 6-year cycle, right? And I'm sure that she's still there.
Yeah,
I'm still here.
Yeah, right, so you're every 6 years, right?
Yeah.
The state thought that was gonna be helpful for hospitals too, right? And so that, this is a lot of work, right? And you don't really see within 3 years an appreciable perhaps difference in what you're doing. Well, that would have been great for hospitals, except they have a federal requirement that for the IRS, through every 3 years, they have to do a community health needs assessment. So they still have to do it every 3 years. Just the counties don't have to. What I understand is that the state, when hospitals do their every 3 years, right? So we'll be doing one in 3 years from now, after 2025, that the counties will not have to do, but we are to touch base and make sure we're still aligned. Because I brought up the question, well, what if we uncover priorities based upon our data that are now not the same as what we had 3 years ago, and that the county has also decided to align with us about those. So there's like, and Selena, I know you probably know about this, so there's like this like midway check-in that the hospitals are gonna do with the counties. Is that how you understand it?
Yeah, I mean, I guess that's what I was assuming. I hadn't gotten any kind of confirmation, but that's sort of what, when we looked at it, when we looked at that initial email, that's.
Yes.
Yeah,
And
that's what we were.
Yeah. And you have the chance to do your community health improvement plan. You can submit it with your CHOP, community health assessment, and the plan at the same time, or you can submit the CHIP 6 months later. You have
Yeah,
that
I think we're
choice.
probably gonna plan on trying to do it at the same time, hopefully.
Yeah, well, I would if I were you. I would get it done. And the community health improvement plan is the action plan that derives from what the data has shown us and where the needs are. And the hospitals, they don't call it a community health improvement plan, they can call it a community service plan, because that's what they call it, that's what it's called. And it's the same thing. And ideally, the state wants hospitals and counties and all these community-based organizations to be aligned in their priorities and what they're working on. So you have to pick 3. That doesn't mean you can't work on other priorities, but they want 3 common priorities. That's their goal. There isn't a statute that says we have to do that, but it's highly, highly encouraged by the state. So, anything else? I mean, I could take you to the prevention agenda dashboard if you're interested, and because I'm curious, and I'm sure you are too, Selena, if they're gonna revise that and change all the metrics and measures, if they're looking at the Healthy People 2030. I'm not quite sure.
I think I've heard that the plan is to change that, and they have been making a lot of updates, a lot more than they used to, more frequently. So I'm hopeful. But Janine, I have an 11 o'clock. I need to jump off. I just wanted to let you know. I thank you, and I've already submitted the poll for the work group.
Oh, okay. Take care, Selena. Good to hear from you.
Thank you
So,
too. Take care.
Yeah, so I mean, I don't know, I mean, I have some counties on the call, and that's, we have some hospitals on the call. I don't know if you want me to go to the prevention agenda dashboard just to take a look at it. What do you think? Yeah, well, we'll pull it up, we'll look at it quick. This is the current dashboard for the prevention agenda. Right, so here we are, right, so they've got,
Sorry, I have the county. Oh, here's this.
okay, yeah, and it does break it down by county, right, so,
If we'd like it by county.
This isn't the dashboard, it looks different.
Yeah, it does look
The
different.
dashboard, the dashboard looks a little different to me.
Already, yeah.
Already, so they must have done something different with it that I didn't even realize, but let's just take a quick look. Okay. So what have they got, 99 indicators, I think they've increased the number of indicators, believe it or not. Oh, maybe they decreased, I can't remember now, this is kind of general overall on those 5, there's the 5, improve health status, prevent chronic disease, those are the priorities you're supposed to choose from during this current, or you have chosen already during this current, cycle, and then if we move down, here's where we start to see the specific indicators, right, that align with the priority area, and they show, the indicated information, where they get the data from is that first column, their objective, where they want to hit, where they want to go, where we're at, the year, whether we're going up, down, whether it's been met. So I think they're gonna have to, because they're working with 20, 30 healthy people, they're gonna have to adjust some of these. And of course, as you see on the left-hand side, those are no longer going to be the priorities. They're gonna be from among those 24 topics that I showed you. And so it'll be a little bit different. So the work group, as we weed through this and as the state continues to update this, I think it'll be a little bit more challenging this time around. That's why we want to meet in October. We'll probably meet every month all the way through to April or May. And then at that point, after having looked at all of our data, primary, secondary, via consensus, priorities are selected.
What else? Alrighty, that's it for our prevention agenda updates, if there are no other questions.
Yeah, I mean, that was a lot of information.
If you think of any, let us know.
Yeah.
Switching gears a little bit.
Yeah, so. Do you want to talk about it?
Sure. So I know we had kind of brought up the idea of a research project in our group. And we definitely had, members who are interested in participating in something like that. We are currently still kind of giving thought to what we really want to accomplish with a research project on a collective level. So right now, we really are focused a lot on the clusters and completing the deliverables with those work groups. So we did kind of discuss, and we thought that we might revisit the idea of a research project at our December meeting. We talked about possibly revisiting it at this meeting, but just because since the clusters are really our focus right now, we are going to table that discussion for this meeting, wait until December, and then hopefully embark on something for the next year.
Yeah, and there are some key people who are part of the collaborative who are very good at researching. Sue McCabe, are you still on? Did she leave?
Not sure.
She might have left, but I know she's a researcher. Nadine is very good at researching. Linda Mermelstein is a great researcher. And I have some experience researching, as does Hannah, as does Brooke, but it's always better to have more minds working on something. We're trying to come up with something, and we're not sure what it's going to be. We're not sure what our question is, but we want it to be reasonable and feasible for us to do. And of course, we've collected a lot of data over the years through the Long Island Health Collaborative. And at one point I was thinking some kind of research on the effectiveness of a collaborative like this, which might involve having some kind of an outside researcher come in and do qualitative interviews. I'm not sure, and I'm not even sure what we're trying to answer with it, but I feel like, we've been in place for a good length of time. We've had tremendous, participation, sustained participation. So there's gotta be some reason why that's happening, and I thought we would maybe investigate that. And I don't know how we would structure it, but these were just some of the ideas that were percolating in our minds. So we figured we'll finish the clusters off this year with their project, and then as a complete group, we could concentrate on some kind of research project with the intent perhaps of getting it published in a peer-reviewed journal or something with everyone who, as authors, collective authors from this collaborative, so you all get to take credit for that. So that's gonna be, we figure we'll hold that off, get past these cluster projects, because they've been taking a lot of time. So that's what that's all about.
All right.
So any ideas you have, send them our way.
Any
We've
questions,
started
any
to put
ideas?
together some ideas, but we're not there yet.
And what's all right? And just some ongoing engagement. Just a reminder about our community health assessment survey. We do have a toolkit available to you to plug into your newsletters, social media, a lot of drafted posts that you can just plug your organization name into and, you know, autopilot schedule some of those to get the word out about our survey. We will be analyzing the 2024 survey results in January.
Goodbye, Linda.
Thank you, Dr. Mermelstein. So anyone who does not have access to that Google Drive and would like to partake in distributing the survey, please let me know and we'll get those materials into your hands.
And just let me say one thing about this survey, and I say it all the time. Data out is only as good as data in. So if we don't have a robust participation among the public, and we depend upon organizations that are part of the collaborative to push it out, right? We push it out too. We have a very aggressive social media campaign. We put money behind boosting. We do everything we can to get those surveys taken. The more, as you know, surveys we can get that are completed, the more representative the sample we have, the richer the data is. So, and it's to your benefit then, right? So it's more, not that we always run a validity and a margin of error statistics on it, but, and we're always still within, whatever that measure is that our analysts told us, we're always within a valid range, but it's better to have more. So we're really working hard, and we ask you to also work hard with us.
And we're also very receptive to your paper copies. We do have a lot of partners who still have a lot of success with that. Please send those our way. And thank you to all of you who bring those paper copies to your
Sue, you bring them all the time. You said,
I know.
Oh, Sue, you are still there. So Sue, I called you out because I know you're a researcher. So I'm hoping maybe we can pick your brain when next year when we really start to delve into some kind of a project, collaborative project.
Would love to participate. Thank you.
Sure.
Thank you. And just some other reminders for you. We have our collaborative communications bi-weekly email newsletter. It goes out to our list of members and contacts. Please send your free events, resources, jobs for inclusion to me directly. We'll make sure those are included. We also have our events calendar where you can submit all of your free events. And of course, we always offer Walk with a Doc, Walk Safe with a Doc. If you would like to have one at your organization, or perhaps you have a physician who's interested in getting more involved in their community, we would love to help you coordinate that. We do all the promotion and we just ask for your efforts to co-promote.
Right, we just held one out in Patchogue with
NYU
Langone, Long Island Community Hospital.
Shout out to Haley Boyle.
Yeah, and their physician spoke. And there's another one coming up in October, I think, right? Yeah, there's one coming up in October.
There is. This is our final AARP Long Island sponsored walk for 2024. That series has been pretty well attended, so we thank you all, who have helped us promote that and who have attended.
Right, and this is where we collect Is this the pre?
Yes, we do pre and post surveys at all of our walks. For the Walk with the Doc sponsored by ARC, we do ask some chronic disease specific questions. So those data sets, as Janine mentioned, will be available to you in November. And we do have some year-over-year data for that now. So we'll be able to show some trends.
Right. So in addition to everything else we do, we walk the talk, right? We say that physical activity is one way to better manage any chronic disease or to avoid a chronic disease taking root, that and nutrition and diet. So we've been out there walking for a good 10 years now. We can't tell you how many walks that we've done. And even if they're not super well attended, we always feel like, well, at least we got to a few people, and this community outreach, community engagement is hard work. So that's all we have to say.
Yeah.
Anybody want to add anything?
And this is just our last note that our final 2024 meeting will be on Thursday, December 5th. You can scan that QR code to register, or the link is here in the slides, or of course on our website.
Right. Yeah, I mean, last year, I'm toying with the idea of maybe holding an in-person meeting at one of the collaborative members' locations, but I'm not 100% sure. But we would not be able to have it as a hybrid meeting then, because you have to have certain technology, and we have to have that here. We lost our large meeting space, that's why we don't have anybody, unless we could fit 5 people here if they wanted to come, but that's about it. So we're thinking about that, but I'm not sure if we'll do that. We might just stick with virtual.
So stay tuned for any updates regarding that. And then if anyone has any further comments or questions, please feel free to unmute yourself.
Yep. Well, I think we gave you back a half an hour or so.
Yeah, just about.
So.
Just one quick thing from me. Thank you. And thanks for this meeting. So I would love to involve students in the research project. I know the discussion is going to happen in December, but I just wanted to mention that as a thought.
Yeah, we always take help. Of course. Yeah.
Yep.
Absolutely.
Yeah, we're happy to offer it.
Yep. And that's it, I think. Anybody? Anything else? And other than that, Nadine, thank you again for having me. Yes, thank you, Nadine. Thank you to everyone on the call for all that you do, both in your own positions, for your own organizations, and what you do in terms of keeping this vital infrastructure together. Really appreciate it.
Thank you all for your time. Yeah, have a great day.
Thank you.
Bye.